Welcome back to the deep dive. Today we're stripping the human body down to, well, its operating system, really. We're looking at the invisible signals that control everything.
Your mood, your energy, your growth.
Even your ability to survive a simple meal. We're talking about the endocrine system.
It's effectively the body's wireless network. And our guide for this is Essential Endocrinology and Diabetes, 6th edition by Richard Holt and Neil Hanley.
And I love that description, the wireless network. Because if the nervous system is the hardwiring, fast, direct, point-to-point.
A telephone call.
Exactly.
Yeah.
Then the endocrine system is broadcasting. It's like a radio tower.
That's a perfect analogy. You have these ductless glands just dumping chemical messengers, hormones, straight into the bloodstream. And those signals go everywhere, but only the cells with the right receiver, the right receptor, actually pick up the message.
Which is why a hormone from the brain can affect your kidneys. It's all about that long-distance signaling. But the book makes a point to distinguish this. It's not the only game in town. There's also paracrine and autocrine.
Right. Paracrine is like whispering to your neighbor, a cell signaling to the one right next to it.
And autocrine is, what, talking to yourself?
Pretty much. A cell releasing a chemical to regulate its own activity. But for this deep dive, we're focused on that long-distance blood-borne traffic.
Okay, let's get to the messengers themselves. The hormones. Holt and Hanley break them into 3 classes. And I used to think this was just trivia for a test, but the structure actually dictates how it works, doesn't it?
It dictates everything. How fast it acts, how long it lasts. The first and biggest group is the peptide hormones.
These are the proteins. Things like insulin, growth hormone.
Exactly, LH, FSH. And because they're proteins, they're water-soluble. They love water, but they hate fat.
Which is a problem because the cell membrane is a fat layer.
It's a lipid bilayer. So they can't get in. They're locked out.
So they ring the doorbell.
They have to. They bind to receptors on the surface of the cell, which triggers a chain reaction inside. It's incredibly fast. You ring the doorbell, the dog barks immediately.
Which is why insulin works in minutes. Okay, so what's class 2?
The steroid hormones. These are the heavy hitters.
Cortisol, testosterone.
Right. Derived from cholesterol, so they're lipids. They don't care about the cell wall. They just slide right through.
Like a ghost through a wall. And they go straight to the command center.
Straight to the nucleus. They bind to receptors that attach directly to DNA and literally change which genes are being expressed. They tell the cell to build new things.
And that explains the time lag. A shot of adrenaline hits you instantly. But a steroid shot for, say, a swollen knee
Takes hours, maybe even a day to work, because it has to rewrite the software and print new anti-inflammatory proteins. It's a slow burn.
And the third class, just to round it out.
The amino acid derivatives, small molecules from tyrosine. So your thyroid hormones, T3 and T4 and catecholamines, like adrenaline.
Okay, so we've got these powerful signals, but the body needs an off switch, right? Otherwise it would just burn out.
And that brings us to what is, the single most important concept in all of endocrinology.
Negative feedback.
The thermostat.
I love this visual. The heater turns on, the room gets warm.
And when it gets warm enough, the thermostat senses it and turns the heater off. That's it. Hormone A stimulates hormone B. When hormone B gets high enough, it loops back and shuts off hormone A. That's homeostasis.
And this is where it gets counterintuitive for diagnostics. If I think a patient's thyroid is sluggish, underactive, my first thought is to check for low thyroid hormone.
That's the logical leap. But the body is already trying to compensate. If the furnace is broken, the brain is screaming at it to work harder. So the pituitary gland is pumping out massive amounts of TSH, thyroid stimulating hormone.
So the first sign isn't low thyroid hormone, it's a skyrocketing TSH.
Exactly. The thermostat is cranked to 100 because the room is freezing. That high TSH is your red flag.
The book mentions positive feedback too, but says it's rare.
Very rare because it's an avalanche, not a loop. The classic example is childbirth. Oxytocin causes a contraction.
Which pushes on the cervix, which tells the brain to release more oxytocin.
For a harder contraction. It doesn't stop until the baby is born.
Let's follow that signal upstream then to the command center, the hypothalamus and the pituitary.
Right, the field of neuroendocrinology. The hypothalamus is the CEO deep in the brain. It takes in all the data, stress, light, temperature, and it barks orders down to the pituitary.
The so-called master gland. But reading the text, it seems like it's really 2 different organs just fused together.
It's a hybrid for sure. The posterior pituitary is just an extension of the brain. It's neural tissue that releases oxytocin and vasopressin.
The water balance hormone.
But the anterior pituitary is true glandular tissue. It's connected to the hypothalamus by this tiny private blood vessel network, the portal system.
And that's where the big players come from. Growth hormone, ACTH, TSH.
All of them. And when this gland goes rogue, the changes are, well, they're dramatic. The book brings up Pierre Marie.
The French physician.
Yes, who connected pituitary tumors to acromegaly. This is excess growth hormone. In a child, you get gigantism. But in an adult, the long bones are fused. You can't get taller.
So you get wider.
Essentially, the hands become huge and spade-like. The jaw protrudes. The soft tissues thicken. It's a very slow, insidious process.
And the opposite is hypopituitarism. The book calls it a domino effect.
It is. If the pituitary fails, maybe from a tumor or trauma, it just stops sending signals. So your adrenal glands, your thyroid, they're perfectly healthy, but they just wither away because they never get the memo to work.
And treatment isn't fixing the pituitary, it's replacing the end products.
Exactly. You just give the patient the final hormone they're missing, like thyroxine or hydrocortisone.
Speaking of hydrocortisone, let's move down to the adrenal glands sitting on the kidneys.
The adrenal axis. This is life and death stuff. The two big pathologies are Cushing's and Addison's. They're mirror images.
So Cushing syndrome is too much cortisol.
Right. And it creates a very distinct look. The book lists them: the moon face, the buffalo hump of fat on the back, and these purple stretch marks on the abdomen.
It sounds like the body is in a constant state of panic.
Yeah, it is. Cortisol breaks down protein to make sugar. So patients get thin skin, weak muscles, high blood sugar. They're cannibalizing their own bodies for stress that isn't even there.
And on the other side, Addison disease. Too little cortisol.
This is a medical emergency waiting to happen. You can't maintain blood pressure. You can't handle stress. But there's this one bizarre telltale sign.
The hyperpigmentation. I highlighted this. Why does low cortisol make you tan?
It's that beautiful, messy biochemistry. The brain senses low cortisol and screams at the pituitary to make more ACTH to stimulate the adrenals.
Okay.
But ACTH is carved out of a much larger precursor protein called POMC, and that big protein also contains a fragment that stimulates melanocytes, the pigment cells in your skin.
No way. So in its desperation to make cortisol, the body accidentally dyes the skin darker.
That's it. So if you see a patient who looks like they just got back from a tropical vacation, but they feel weak and dizzy,
Yeah.
you have to check the adrenals.
That is a fantastic clinical pearl. Okay, let's go to the neck. The thyroid, the body's throttle.
T3 and T4. Remember, T4 is the storage form. T3 is the active gas pedal.
And again, it's a hyper versus hypo situation. Hyperthyroidism.
Is the engine racing in neutral, usually Graves' disease, weight loss despite eating everything, heat intolerance, and sometimes that characteristic staring look, the exophthalmos.
And hypothyroidism is the engine stalling out.
Cold, tired, foggy weight gain. Incredibly common, and as we said, you diagnose it with that high TSH.
All right, we've covered the signals and the glands. Now we have to tackle the whole second half of the book, the big one, diabetes.
It's the defining metabolic challenge of our time. And the history the book gives is so grounding. The word diabetes comes from the Greek for siphon.
Because fluid just passes right through you.
Exactly. And Aridius, in the 2nd century AD, called it a melting down of flesh and limbs into urine.
Which is terrifyingly accurate for what it was back then.
It was. Before 1921 and the discovery of insulin, it was a death sentence. You starved no matter how much you ate.
Let's parse out the types because they're so different. Type 1 diabetes is
an autoimmune assassination. The body's own immune system attacks and destroys the beta cells in the pancreas. The insulin factories are gone. It's an absolute deficiency.
So the key to the cell is just gone. The sugar is in the blood, but it can't get in.
Starvation in the midst of plenty. That's the perfect description.
Whereas type 2 diabetes is more complex.
It starts with insulin resistance. The pancreas is making plenty of insulin, sometimes too much, but the cells just stop listening. The signal is ignored.
The boy who cried wolf.
Right. And eventually, after years of overworking, the pancreas just gets exhausted and can't keep up.
Okay, the book is very clear about the numbers. For any students listening, what are the hard diagnostic lines?
You need to know these colds. A fasting plasma glucose of 7.0 millimoles per liter, that's 126 milligrams per deciliter or higher.
7.0. Got it.
Or a random glucose of 11.1, that's 200, with symptoms.
And what about the HbA1c? We hear about that all the time.
A finger prick is a snapshot of your bank balance right now. HbA1c is your 3-month credit report. Glucose sticks to red blood cells, it sugarcoats them. Since red blood cells live about 3 months, The A1C gives you the average blood sugar over that time. It tells the real story.
And the danger here is that the balance between insulin and its opposite, glucagon, is broken.
It's a broken seesaw. Insulin stores energy after you eat. Glucagon releases stored energy when you fast. In diabetes, that regulation is just gone.
So what happens acutely? In type 1, you can get DKA.
Diabetic ketoacidosis, a true medical emergency. With no insulin, the body thinks it's starving and starts burning fat like crazy. The byproduct is ketones, which are acidic.
The blood literally turns to acid.
Yes, and without insulin, it is fatal.
And the other side of that coin is taking too much insulin. Hypoglycemia.
Hypos, sweating, confusion, palpitations. The brain runs only on glucose, so if you bottom out, it's lights out.
But the real damage, as the book points out, is the slow burn, the chronic complications.
It's a slow poison to the blood vessels. We split it into microvascular, the tiny vessels, and macrovascular.
Micro gives you...
Retinopathy, so blindness, nephropathy, kidney failure, and neuropathy, nerve damage in the feet.
And macrovascular.
Heart attack and stroke. Diabetes is a massive accelerator for cardiovascular disease. That's what usually kills patients with diabetes.
So how do we manage it? Type 1 is pretty clear cut.
Type 1 needs insulin, period. Full stop. You have to replace what's missing.
But type 2 has more options.
Lifestyle is the cornerstone. Diet, exercise. But the first-line drug is almost always metformin. It's brilliant. It tells the liver to calm down and stop making extra sugar.
And now we have these newer drugs, the GLP-1 agonists.
They're a revolution. They mimic a gut hormone that tells your brain you're full, so they directly tackle the obesity that's driving the resistance. It's a game changer.
Before we wrap up, I want to touch on this very modern problem the book highlights, the incidentaloma.
Ah, the tumor of technology.
It sounds made up, but it's a real clinical headache, isn't it?
It is. We scan everyone for everything now. You get a CT after a car wreck, and the report says, by the way, there's a lump on the adrenal gland.
And 20 years ago, you never would have known.
Never. So now you're stuck. Is this thing dangerous? Is it pumping out hormones? Or is it just a benign lump doing nothing?
You have to become a detective.
You have to go back to those feedback loops. You measure the hormones and see if the lump is silent or if it's functional. It's a great reminder that data isn't the same as a diagnosis.
A perfect transition to our closing challenge. Let's give our listeners a review question to chew on.
Let's do a classic board review case.
All right, everyone, here's the setup. A patient comes in with rapid weight loss, but they have a huge appetite. They're sweating, they can't stand the heat, and you notice their eyes have a bit of a staring, bulging look. You run the labs.
And remember, think about the feedback loop.
The results come back. TSH is undetectable, basically 0. But the free T4 is sky high. So the question is, what's the most likely diagnosis, and why is the TSH so low?
I'll give you a moment. The diagnosis is primary hyperthyroidism, almost certainly Graves' disease. The T4 is high because autoimmune antibodies are forcing the thyroid to work overtime.
And the TSH, why is it 0?
The TSH is 0 because the pituitary is doing its job perfectly. It sees all that T4 flooding the system and it slams on the brakes. It cuts TSH production to 0 to try and stop the madness.
The thermostat has shut off completely because the house is on fire.
That's it exactly. If the TSH were high and the T4 were high, you'd think pituitary tumor. But low TSH with high T4 points the finger straight at the thyroid itself.
Fantastic. Well, that brings us to the end of our deep dive into essential endocrinology and diabetes. It's a complex system, but once you learn the language,
the feedback loops, the hormones, you start to see the conversation happening inside the body. It really is all about balance.
Thanks for listening, and we'll catch you on the next deep dive.